Hi everyone, welcome to today's rapid review lecture. Today's topic will be the pathology of the musculoskeletal system. My name is Stephen Gopaul and I'm a final year medical student, and I'm incredibly excited today to talk to you about pathology of the musculoskeletal system firstly, and also I'm really thrilled to be able to kick off this wonderful series which all of us at UIMS hope will be really useful to all the preclinical students who will be doing their pathology exams in the coming months. So without further ado, I will start today's lecture. Just a quick disclaimer, I'm not a doctor, I'm not a pathologist, and so I will not be talking to you about pathology slides and the histology as well. Purely because I'm not an expert in that, and I want to make this lecture as high yield as possible and only include information that you can really retain, and hopefully with the other things that you're already doing at university and in your own spare time that you're studying, this can be a nice supplement for you to get a really nice grasp of musculoskeletal pathology. And secondly, I would really hope that you do not use this lecture as the only source of information. Please use all of your university materials alongside this for your revision. So today's lecture is going to be, well, I've broken it up into the most simplest of ways. So I'll be talking about each component of the skeletal system, starting off by bones, and I'll end with the neuromuscular junction. All of the information that I've used to create this presentation has been taken from Hussein Sattar's Fundamentals of Pathology, or Pathoma, as many of you may know, and also Edward Golyon's Rapid Review Pathology. Both of those are some of my favorite books that I've read during medical school. And you might notice that in the top right corner, I have got my email there, and that is for anyone who would like to get in touch with me to discuss this lecture, or if they would like to receive any advice on pathology, as I do tutor it privately. So moving on to the first topic of today, we're going to be talking about bones. And the first pathology that we will talk about is achondroplasia. So achondroplasia is caused by a mutation in the FGFR3 gene, which is the fibroblast growth factor 3 gene. It is an autosomal dominant condition, and what this condition causes is defective cartilage proliferation in the physis of the bones. And as you can see here in the image right next to the information, it presents as dwarfism. And the dwarfism, as we can see here, tends to be more extremity based, and as we can see that the patients that suffer from achondroplasia tend to have a normal head and a normal trunk or chest, but their extremities are incredibly short and are not relative to their ages, as we can see the progression from a toddler at 3 years old all the way to 14 years old and then an adult. Another feature is that they often have trident hands, and this is where, as you can see in the information, the 5 fingers are basically broken down into 3 groups, where you have the thumb, and then the first 2, or the second and the third finger as a group, and then the 4th and the 5th is the other group. And we can see that we know that this is very noticeable in early childhood and is one of the cardinal signs for suggesting that the patient may be suffering from achondroplasia. They tend to have no mental retardation. They have completely normal intelligence quotient, IQ, and they have a normal life expectancy. It's no different to anyone else, and they also remain fertile. Treatment-wise, there isn't any treatment, unfortunately. So all of these, or anyone that does suffer from achondroplasia will be shorter in stature for the rest of their lives. Just a note on the FGFR3 gene, its overexpression essentially inhibits growth. And some people or some pathologists have said that a risk factor for achondroplasia is increased paternal age. So, for example, if a father is above the age of 35, and so that is a risk factor for achondroplasia. Second condition is Rickets. So Rickets is a defective mineralization of osteoid. You might be wondering, what is osteoid? So osteoid is basically produced by osteoblasts, and it is mineralized with calcium and phosphate to form bone. We know that the etiology of Rickets is low vitamin D, and this low vitamin D tends to cause low calcium and phosphate, which are important constituents for bone, as I've just mentioned. The clinical presentation, as we can see in this child here, is that they tend to have the bowing of the legs. They usually also have rachitic rosary. Rachitic rosary is a type of protruding lesion which is usually seen really clearly here. It's not clear on this patient, but it's usually clear in the parasternal channel. Often they have pectus carinatum. Pectus carinatum is when you have a protrusion of the chest. They also have frontal bossing. So by frontal bossing, I mean the frontal aspect of their forehead is usually quite prominent, and it's usually it's more not protruding, but it's definitely more prominent in terms of the other aspects of the skull. They usually have wide sutures, and it's because of these wide sutures that you tend to have the frontal bossing. And they also have delayed fusion with their bones as well. How can we treat Rickets? So obviously, as you know, the disease is caused by low vitamin D. And so the easiest way we can combat Rickets, or we can prevent Rickets, is by having vitamin D supplementation and also adequate time in sunlight. And why do we need adequate time in sunlight? That's because sunlight will activate 25 hydroxylation by the liver, and then further hydroxylation by the kidney to synthesize the vitamin D. Next pathology is Osteogenesis Imperfecta. So Osteogenesis Imperfecta is a defect of bone resorption that causes bone to be brittle. And what I mean to say by brittle is that the bone is very weak. As you can see, the bone is very curved here, very malleable, and this can cause pathological fractures, obviously, as you can see in this image here. Genetics-wise, it's a autosomal dominant defect in type 1 collagen. I'm not going to go into the function of type 1 collagen, as I think that would be a wrong thing to do right now. And also the fact is that there's many different types of collagen, but osteogenesis imperfecta tends to affect type 1 collagen more often. And it also has been linked to mutations possibly in these following two genes. So the COL1A1 gene and also the COL1A2 gene. How does it present? So as you can see that it usually presents as pathological fractures in the bone rather. And the patients tend to have blue sclera. That's a very noticeable sign when you're examining the patient. And also deafness. You might be wondering why deafness. And deafness because the bones of the middle ear are also actually fractured quite often in these patients. So that's the cause of the deafness there. The treatment is very one-dimensional. It's usually bisphosphonates, and the bisphosphonates basically give more structure to the bone and give it more solidity. Osteoporosis is the next pathology, and once again, this is another defect in bone resorption that causes abnormally thick and heavy bone that fractures easily, and it's mainly caused by deficiency in osteoclasts. So we know that osteoblasts are needed to form bone, and we know that osteoclasts are needed to break down bone. And this condition is a autosomal recessive condition usually. And in autosomal recessive cases, it's very severe. It can also be dominant. And in dominant cases, it's usually less severe. And as I mentioned, dominant is less common as well. It has also been linked to carbonic anhydrase, carbonic anhydrase 2 mutations, which I will discuss later on in the clinical presentation. So the first clinical presentation, because the bone is abnormally thick and it's very heavy, you may think that it wouldn't be easy to fracture, but it's actually the exact opposite. And it can cause pathological fractures. As we can see in the image here, in a normal X-ray, usually you wouldn't find the diaphysis or even the cortex of the bone. It wouldn't usually be very dense, but on this X-ray image, you can see it's very dense. That is a significant sign for this disease. And also we can see that the fibula here, which is actually broken right there. They can also present with anemia, hydrocephalus because of the reason of heavy bone in the skull causing compression and a buildup of CSF. There can also be vision and hearing loss, once again due to the solidification of the skull causing impingement on those on the nerves. And finally, renal tubular acidosis. So it can cause renal tubular acidosis because the carbonic anhydrase 2 mutation obviously causes renal acidosis because there is decreased bicarbonate, HCO3, and that in turn leads to metabolic acidosis. Treatment for osteoporosis is vitamin D, gamma interferon, which are starting to have more promising effects on prognosis, and also bone marrow transplantation. Vitamin D is used because it appears to stimulate dormant osteoclasts, and that can sometimes help in ensuring a good balance between osteoblasts and osteoclasts. And as I mentioned, gamma interferon is being used more often these days, and that's because it has more long-term benefits as well. So the next slide is on osteoporosis. Osteoporosis is a very, very common pathology in the elderly, but it can also affect the youth and young patients as well. It's mainly a pathology of the bone matrix and the mineralized bone, where it causes a deficiency in bone matrix and the mineralized bone. There's also a decreased thickness of cortical and trabecular bone. So as you can see in this image, normal bone is not very porous. It's usually relatively thick, whereas in the bone showing osteoporosis, you can see there's a lot of porous bone. There's a lot of gaps, and the thickness is definitely decreased. Its epidemiology, it's most common in females and also smokers. Smokers, why? Because smoking actually, it causes smoking inhibits osteoblast activity. And if we stop smoking, we can inhibit this. And as a result, the bone will be much stronger. There are also different types of osteoporosis. Just above in the previous point, I also said most common in women. I'll discuss that in the pathogenesis, why it's more common in women. So back to the types. There's two types. We have primary and then we have secondary. So primary, it can be either idiopathic, it could be postmenopausal, or it could be senile. Idiopathic is simple wear and tear as you get old. Your bone density tends to decrease. Postmenopausal, because we know that estrogen is incredibly important in enhancing osteoblasts and inhibiting osteoclasts. Senile, once again, as you get older, your bone mass tends to decrease. Secondarily, it can also be caused by medication. So the two types of medication that we're talking about here are glucocorticoids and also low molecular weight heparin. And it can also be caused by hypogonadism and also space travel. So as I mentioned about the pathogenesis, we know the role of estrogen here. It enhances osteoblasts and it inhibits osteoclasts. We know that there's an important role in cytokines. So the effect on the bone mass is mediated actually by inhibiting secretion of these following cytokines, so interleukin-1, interleukin-6, and TNF, because they actually modulate osteoclastogenesis. And when these cytokines are released, they actually enhance the expression of the rank L receptor or the ligand and the genes, which increase osteoclastogenesis, and as a result, it causes fractures and also decrease in bone mass. So that is its pathogenesis. Its clinical presentation, usually it's bone pain. Bone pain can tend to be more cervical, it can be lumbar, but really it can be anywhere. We can also see fractures in the vertebrae, And when we have these fractures, it usually causes kyphosis. So we know that scoliosis is a curvature of the spine, and we know that kyphosis is either a forward bending, or it is forward bending, sorry. And there will obviously be a loss of height because of loss of bone mass. It's also quite common to see fractures of the wrist, especially Colles fracture. I won't go into Colles fracture too much, as this is a pathology lecture. How do we diagnose it, or what would we look to find out about this osteoporosis? So we would do a DEXA scan, so we would do a bone densimetry scan to simply see the density of the bone. We could also do a serum calcium phosphate and parathyroid hormone as well, along with alkaline phosphate. And treatment, as I mentioned earlier, simply we have to exercise more often. We have to stop smoking, so smoking cessation. As smoking cessation tends to inhibit osteoblasts, and vitamin D and calcium supplements are also very important in making sure that the constituents of bone can be formed and solidify the bone. Bisphosphonates, once again, and denosumab, which is actually an anti-rank drug, and by anti-rank, it will inhibit osteoclastogenesis. There is, as you'll see, I've put a question mark and a query around estrogen replacement therapy, and that's because it's not, there isn't a general consensus whether hormone therapy is useful, because obviously we know the risks of hormone therapy is that we can also have some hormone-dependent cancers as well, such as breast cancer, for example. So we can use ERT, but it's usually very selective and very dependent on the clinician providing the treatment plan. Paget's disease. So Paget's disease is an imbalance of osteoblasts and osteoclasts. It's most common in men over the age of 50 years, and its etiology is possibly due to a viral infection, for example, paramyxovirus, which can cause an infection of osteoclasts. There are three different stages. So there's an osteoclastic phase, which is the initial phase where you have more breaking down of bone. So during this breaking down of bone, you could possibly have fractures, followed by the next stage, which is mixed. So that's when you kind of have a normalization of osteoclastic function and osteoblastic function. And then the final stage, which is the osteoblastic phase, where you have increased bone production. And you'll see in the image here some of the manifestations of Paget's disease. Usually you'll have bone pain, very, very common. It's also very non-specific for many pathologies. You tend to have bowing of the limbs, or bowing of the limbs. There's also kyphosis. And there can be hearing loss and lion-like facies or facies, which is more common in the osteoblastic phase, which tends to affect the head more often. And it's not uncommon to see people going up in hat sizes because of the increased bone in the skull, causing it to expand. And that can also cause headaches, for example, because it can cause compression of some structures. The diagnosis, once again, you'll notice that with musculoskeletal pathology, the diagnosis is usually very similar. The algorithm is very similar. So it's usually an X-ray, your serum ALK, phosphatase, and once again, bone scans. Treatment is usually with bisphosphonates and calcitonin. Calcitonin, because calcitonin can inhibit osteoclasts. And by inhibiting osteoclasts, we can prevent bone from being turned over much sooner than it already is. There are some complications for Paget's disease. So notably pathological fractures, as I mentioned in the initial stage. There is also a risk of developing some pretty nasty bone cancers, such as osteosarcomas, for example. And there's also a risk for some cardiac dysfunction in the form of heart failure with high output heart failure, which is caused by AV shunts in the bones. So the following two slides will be more to do with complications of surgeries, for example, and also just in general complications of trauma, but they do have some cellular pathology basis. So the first one is osteomyelitis. You can see in this X-ray here of the left foot, where you can see in the first phalanx here that there is some sort of lesion which is expanding, and it has actually occupied quite a bit of space in the joint space as well, and also in the surrounding outer rim of the bone, almost in the form of an exocytosis. And this is a bone marrow and a bone infection. It can be that there are many ways that you can develop osteomyelitis. Most commonly, it's hematogenous, so we're talking through the blood. It can be an operative complication, as I mentioned. Sometimes when we have to, or when there are fractures, there can be the need to open up the skin and then operate on the bone in an exposed environment, which then can cause an infection to develop in the wound site and then to the bone. And thirdly, it can also be caused by direct contact. So we're talking trauma here, some nasty injuries, which can lead to usually non-colonizing bacteria to enter the bone and the skin and cause a nasty infection. Agents, usually it's Staphylococcus aureus, which tends to cause most of the infections. Can be caused by TB, and the infection where TB causes the osteomyelitis is known as Pott's disease. And it's usually more common in the vertebrae. Salmonella can also cause osteomyelitis, but it's also linked with sickle cell disease. And then finally, Pseudomonas, which is more common, or more commonly seen in diabetics and also IV drug users. So its clinical presentation tends to affect the metaphysis of the bone, and as it's an infection, there will obviously be fever, there will be bone pain, and there could also be abscesses. In this image here, it seems like this lesion is on the border of an abscess. And when we do have abscesses, there can be a lot of pus, so it can be a suppurative and a smelly lesion, which usually signifies to the doctor that there is an issue of a potential infection. If the infection is quite progressive and not treated straight away, or at least in the acute phase, the bone can become devitalized, and at that point, the bone is usually called a sequestra. And if it's chronic, then there's usually sclerosis, and we know we call this involucrum. So once again, diagnosis. We know it's an infection, so we know that we could do some labs. And so a simple full blood count would show us some leukocytosis. We could do a culture of the wound, and then simply an X-ray and then an MRI, CT, just to assess some soft tissue damage as well. Treatment-wise, antibiotics are the mainstay. Most of the time, the patient will be given antibiotics, and there could be some surgical debridement. By debridement, I mean kind of resection or removal of necrotic areas of the bone. And some complications of osteomyelitis could be compartment syndrome secondary to it, because if it's in the metaphysis of a long bone, for example, let's say the femur, it could cause, sorry, not the femur, let's say the tibia or the fibula, it could cause the lowest of the lower limb to have a lot of, or an increased pressure in the entire compartment, which can cause a lot of issues, and it may need relieving in the form of a fasciotomy. So there is a risk of compartment syndrome, which we have to be very aware of. And then the final bone pathology that I want to talk about, which is also a complication, is avascular necrosis or aseptic necrosis. So this is ischemic necrosis of the bone and the bone marrow. Etiology is usually caused by trauma, so trauma in the form of fractures, and it can technically present in any part of any bone, but more commonly it's usually present in the scaphoid and the femoral head, but it can present in the talus, for example, and also the proximal radius. Once again, glucocorticoids and alcohol can also be causes for the avascular necrosis. In typical presentation, so as I mentioned, these are the sites that are usually involved in avascular necrosis, and the patient would usually present with chronic bone pain. You would think that if they had the operation and the fracture was treated, the pain would settle, but sometimes it doesn't subside, and so chronic bone pain for more than 3 months after the operation is a sign that there could be avascular necrosis. And usually this causes gait, and also maybe restricted movements as well. So yeah, can cause gait. Diagnosis, unfortunately, an X-ray is not very sensitive for avascular necrosis, and as a result, it's much better to use MRI or CT to really assess the soft tissue damage. And as you can see in the image below, the normal head can become really necrotic after it's been ischemic for a certain period of time. And I think one of the reasons why the femur is also affected quite commonly, especially in hip fractures, is because of the blood supply. As we can see that there's many different, you could say, contributories to the head of the femur, and a fracture usually tends to affect the head or the neck, and it can cut off the blood supply, which could cause the avascular necrosis in that case. So the treatment of it needs decompression, because obviously there'll be lots of swelling, and we need to reduce the fracture. There may be a need for a bone graft if the bone is incredibly necrotic or completely dead. Joint replacement is a tricky topic because it really depends on the age of the patient and also the quality of life. And then bisphosphonates to give the bone a bit more to give the bone a bit more strength and solidity. So that was bones. The next section that we will talk about is joints. So the pathologies that I want to talk about in joints are mainly going to be osteoarthritis and rheumatoid arthritis. So osteoarthritis, it is a degenerative disease. So it's obviously a chronic disease, and it's a progressively non-inflammatory degenerative condition of the articular cartilage. It's not affecting the bones. That would be osteoporosis, but this is osteoarthritis. So it's affecting the cartilage. And the risk factors for osteoarthritis are increased age, so typically above 60 years, although it can be juvenile, very rarely, well, not very rarely, it's not uncommon to find juvenile osteoarthritis, but that's usually more linked to the following disease that I will mention here: Pear's disease, any sort of developmental dysplasia of the hip, and also possibly even a slipped upper femoral epiphysis as well, which can cause this osteoarthritis at a younger age. Obesity and trauma. Obesity because of just the sheer force of the amount of weight which is causing the axis of the joint to possibly become displaced, or at least not stable because of the sheer weight load going through it. And trauma, because trauma tends to cause fibrosis and sclerosis, and this can cause a degeneration of the articular cartilage. So its pathogenesis is it's usually caused by cytokines, once again, which will activate the metalloproteinases. And these cytokines, once they activate the metalloproteinases, they can cause degradation of the proteoglycans and the collagen that supports the joint. And as a result, we can see that there's a reduced joint space here. There can be some subchondral sclerosis. You can't see it very clearly in these images, but there will be some subchondral sclerosis along with this reduced articular space. And there will also be some osteophytes in the margin of the cartilage. Usually in an X-ray, once you see this, it's very distinctive of osteoarthritis. Clinical presentation, it can affect any joint. As I mentioned, as you get older, it becomes more prominent and becomes more common just because of the wear and tear. So it can affect any joint. There will obviously be pain whilst moving. There can be some joint stiffness as well in the mornings, and the duration of the joint stiffness is actually the differential for distinguishing between rheumatoid arthritis and osteoarthritis. Osteoarthritis tends to be a lot longer, or sometimes throughout the entire day, and it actually gets worse on usage of our joints as we move about a lot. There can be restricted movements because of the reduced joint space. There can be crepitus. By crepitus, I mean creaks and cracks. Sorry, creaks really. They may be heard when you move in your joints. There can also be enlargement of the proximal interphalangeal and distal interphalangeal joints with Bouchard and Heberdine nodes, respectively, in those joints, which are a sign of osteoarthritis once again. Treatment, obviously exercise does wonders for almost every single disease. Weight loss to help with the weight load on our joints. Pain relief, this can be in the form of paracetamol or ibuprofen or NSAIDs alongside the ibuprofen. And even glucocorticoids and steroid injections in the joints, they can give some pain relief. And if none of those work, then we can obviously consider joint replacement. These can be hemi in the form of, you could say, a semi-joint replacement or a total joint replacement. And yeah. So rheumatoid arthritis. Rheumatoid arthritis is another chronic systemic autoimmune disease that will cause inflammation. In terms of genetics and epidemiology, it is linked with the HLA DR4 gene. That's a strong association with that, and it's most common in women aged 30 to 50 years. The pathogenesis is usually caused by CD4 plus helper T cells becoming activated and then releasing tumor necrosis factor. And essentially what this causes, it causes the synovial cells, which are in the joint space, to become inflamed. And then they trigger B cells to produce rheumatoid factor and also IgM antibodies against the FC portion of the IgG. And basically these two, the rheumatoid factor and the IgM antibody, they form immunocomplexes. It's a hypersensitivity type 3 reaction, and it also involves complements and the complement system becoming activated, and this causes a lot of leukocytes and other chemotactic agents to enter the joint space and causing chronic inflammation and also pannus proliferation, or sorry, formation, and the pannus will proliferate and release even more cytokines, interleukins and tumor necrosis factors that will eventually destroy the articular cartilage, and it will lead to the fusion of the joint by scar tissue, and this is called ankylosis. So clinical presentation, as I mentioned, in osteoarthritis, there's also some morning stiffness, but that morning stiffness tends to continue throughout the entire day. The morning stiffness in rheumatoid arthritis is usually usually between 30 minutes and 60 minutes, and it usually resolves after usage of our hands or any joint that is affected. There's usually a symmetric pattern, so if your right is affected, your left will also be affected, and it tends to affect the most peripheral parts of the joint. So it tends to affect the metacarpophalangeal joint and then the proximal interphalangeal joint. There can be some ulnar deviation, so I don't think you can see it very clearly in this patient, but there will be some ulnar deviation such as this. There may be a swan neck deformity as well, whilst it being ulnar deviated. And as it's a rheumatic disease and an autoimmune disease, there will be fever, weight loss, vasculitis, and in the knees, we can often see a Baker's cyst. Obviously, the other kind of interstitial systemic rheumatoid diseases such as interstitial lung fibrosis, pleural effusions, and then chronic disease in the immune, so lymphadenopathy, sorry, can also be present. Diagnosis, as you can see, I have mentioned rheumatoid factor here, but rheumatoid factor isn't the most sensitive of tests for rheumatoid arthritis. Usually the most sensitive test is anti-CCP, so cyclic citrulated P, along with the IgM autoantibody versus the FC portion of the IgG, rheumatoid factor, and also for full blood count, so we can have fever and anemia as well. The treatment, usually the patients are started off on NSAID, so ibuprofen, for example, and if that doesn't seem to resolve, it can usually be given disease-modifying anti-rheumatic drugs, for example, methotrexate, gold, penicillamine, sulfasalazine, drugs such as that. And I think there is a shift towards DMARDs being used more often nowadays because it has a better prognosis further down the line. So these are the treatments usually. There is also an option for some surgery in the form of joint replacements, some arthroplasties or arthroscopies as well. And some shaving of the joints as well. So this is rheumatoid arthritis. Rheumatoid arthritis, as I have mentioned, it doesn't always have rheumatoid factor present. And so sometimes it can be present, sometimes it may not be present. And it would also be good to mention that there are other joint diseases and arthritic pathologies, which sometimes have seronegativity. So by seronegativity, meaning that they do not produce rheumatoid factor. So those types of arthritis could be, for example, Reiter's syndrome. They could be reactive arthritis. It could be arthritis linked with inflammatory bowel disease as well, and also ankylosing spondylitis, and all of them, as rheumatoid arthritis has a HLA-DR4 gene association, the seronegative pathologies tend to be HLA-B27 associated. So these are the common pathologies of the joints. Obviously, there's gout and other pathologies, but I wanted to keep it as high yield as possible and only mention these two. So muscles. So the first muscle pathology that we will talk about is dermatomyositis. This is an inflammatory disorder of the skin and the skeletal muscle. It is sometimes associated with gastric carcinoma, but to be completely honest, I think it has a very unknown type etiology, where it's not very, there's no general consensus. Clinical presentation, usually there's bilateral proximal muscle weakness, and it becomes more distal later on as the disease progresses. And with this weakness, there can sometimes be or there will be muscle fatigue actually whilst walking. So sometimes people may not even have the energy to walk a few steps or even walk upstairs to their bedroom, for example. As it's a inflammatory disorder, there would obviously be fever, weight loss, and a heliotropic rash here in the upper eyelid, as you can see in this patient. There can also be dysphagia, as this is going to be affecting skeletal muscles. And you will have red papules on the elbow and also on the knuckles and knees, usually more common in the knuckles, and they're very distinctive. These are called Gottron's papules. As you can see, it's not a very clear image, but there are papular lesions here on the knuckles of each digit. How do we diagnose it? Once again, you can do a wide variety of tests. You can do creatinine kinase test. You can do a anti-nuclear antibody test. You can have a myositis-specific antibody. But more commonly, we tend to diagnose it clinically, and to completely confirm the diagnosis, a biopsy has to be performed. How do we treat it? Sorry, another point for diagnosis, actually, we can use camera tests. So, for example, we could choose to do a esophago-gastroduodenoscopy, so a camera through the mouth, and that could possibly show us a gastric carcinoma. We could also have the tumor markers as well in the case of gastric carcinoma, once again. Treatment, tend to avoid the sun, and the mainstay is usually corticosteroids and methotrexate, and usually that tends to lead to more symptomatic relief, which is always good for the patient, and very rarely there's surgery. And then the last muscular pathology is Duchenne muscular dystrophy. So this is a chronic muscle wasting and replacement of skeletal muscle by adipose disorder. It's a X-linked recessive disease, and it's usually caused by a mutation in dystrophin. So dystrophin is usually anchoring the actin to the membrane glycoprotein, and when the dystrophin is deficient, or if it's not even there, we can have a bit of an unorganized cytoskeleton, and the extracellular matrix may not be stable and solidified, and it can cause a lot of disbalance. So clinical presentation, usually you have symptoms between 2 to 5 years. They can even present at 1 year old. Why 2 to 5 years? Because it's usually more common that children start walking, or at least most children are walking definitely by 2 years old. And by 5 years, they can perform some complex gross motor activities, which can actually tell us if they have got a muscular dystrophy. There will also be muscle weakness because of this wasting. Gower's maneuver. So Gower's maneuver and pseudohypertrophy are probably the most distinctive features of Duchenne muscular dystrophy. So a Gower's sign is when a child has to basically get on all fours to be able to get themselves up, as you can see in this image here. And the pseudohypertrophy of the calf muscle here is usually because, as I mentioned, the muscle has been replaced by adipose. And so this is actually pseudohypertrophy. It's actually full of adipose tissue rather than muscle tissue. There can also be a waddling gait as a result of this muscle wasting and lack of skeletal muscle, and gradually there will be some respiratory and some cardiac involvement. Usually the cardiac involvement causes cardiomyopathies, which can lead to heart failure and arrhythmias. And when there's respiratory involvement, there's usually respiratory muscle weakness, which leads to respiratory failure. And in those cases, the prognosis is very poor, and in general, death usually occurs by 20 years of age in those with Duchenne muscular dystrophy. Diagnosis, I forgot to mention here, but clinical or physical examination, as we can see with the Gauss sign and the pseudohypertrophy. A biopsy would be very definitive. We can also perform electromyography to see if there's any muscle tissue which is actually conducting any action potentials, and then finally we can have serum creatine kinase, which is very significant as well. Treatment-wise, it's usually supportive therapy, as there are no set treatments to be able to kind of cure this dystrophy. Another form of a dystrophy is Becker muscular dystrophy, and this is a much milder disease, and the presentations aren't usually as significant or severe as Duchenne. So this is the Duchenne muscular dystrophy. I think now would be a good time to take a break. So I suggest for those who are watching to take a 5-minute break, and I'll just pause the stream and I'll come back to discuss tumors and the neuromuscular junction pathology. So see you back in 5 minutes. Okay, so welcome back. Had a 5-minute break. And now we can continue with the final two topics. So tumors. Just before I start off, the tumors that I'm going to mention are predominantly primary tumors of the bones, bones, soft tissue, and also adipose and fat and muscle as well. Sorry. But the tumors that are most common actually tend to be secondary tumors. So these tumors can be metastatic cancers from the prostate or the breast, and they tend to be quite common rather than primary tumors of the bone. So these primary tumors, we can classify them as either benign or malignant. So if they're benign, usually they're oma, or actually oma is actually a mass of cells, but usually they end in oma. And if it's malignant, they tend to be sarcoma. So in musculoskeletal pathology, I think the easiest way of describing tumors is to break it down into either bones, cartilage, miscellaneous or unknown cell origin, and then also adipose tissue and muscular tissue. So to start off, so the first thing that we're going to talk about is going to be a benign tumor of the bone. So this is a osteoma. This image shows here. So an osteoma is a benign tumor of the bone. It's usually more common in males, and it's associated with Gardner syndrome, which is polyposis syndrome, which is a form of familial adenomatous polyposis. So multiple polyps in the digestive tract. Its clinical presentation usually tends to affect facial bones. It's a non-movable mass. We'll discuss one tumor which has movable potential further down. And it can be painful sometimes, and sometimes it's not usually very painful. The diagnosis, this is going to be a really, really common theme in the tumors. It's in general, it's usually an X-ray and is CT indicated, and then to confirm it with the biopsy, as pathology is about confirming things with biopsies. Treatment, we can treat them usually with an NSAID or maybe even paracetamol sometimes, and surgery is only if there's a bit of pain or there's some aesthetic reason for removal of the mass. And this image here below actually shows the approach to taking out one of these tumors. So yeah. Osteoid osteoma. So once again, this is another benign tumor, but this is a benign tumor of the osteoclast, and this is surrounded by a rim of reactive bone. So this is the reactive bone in this X-ray. As we can see, the middle finger here, it's obviously very swollen, but this is a tumor of the osteoclast, which is causing increased bone production. Epidemiology, it tends to be more common in younger adults, so less than 25 years, with equal distribution. It can affect males and it can affect females. So clinical presentation, as I've just mentioned, tends to affect the cortex of the proximal bones, also quite common in the feet. And it's a bone pain that resolves with aspirin. And this bone pain tends to be more common at nighttime as well, but it does resolve with aspirin. Diagnosis, once again, the standard 3 X-ray, CT, biopsy confirmed. Treatment, NSAIDs again, curettage to remove this kind of reactive bone here, just to reduce the size of the actual tumor, and radiofrequency ablation, which can actually quite nicely reduce the size of the mass, and so this is an osteoid osteoma. And next is osteochondroma. So osteo, obviously we know it affects the bone, and a chondroma is going to affect cartilage. So as you can see in this X-ray here, this is an X-ray of the knee joint really. This is the femur here. This is the patella. Sorry, it's not a patella. This is the femur. The patella is usually here. You can't see it. And then this is the tibia, and then this is the proximal fibula. And it's a benign tumor of the bone with overlying cartilage. So that's why it's more common in males, especially younger kids really. More common in the 10-year-old bracket, because their bones are still fairly cartilaginous, and they're not fully formed because the physis hasn't fused. And as a result, they can have an osteochondroma. Clinical presentation is usually in the metaphysis of the distal femur, and exotosis of the bone. So exotosis is a big kind of a tennis ball-y mass, which is reactive on the outer rim of the bone, and very, very rarely, but the overlying cartilage can become a chondrosarcoma. And a chondrosarcoma is obviously a malignant tumor of the cartilage. Once again, diagnosis same. But with the osteochondroma, we can use radiotherapy, chemotherapy, and surgery. And usually surgery is very kind of last resort. It would tend to be more kind of limb-sparing surgery rather than any other options. But we try and use radiotherapy and chemotherapy to reduce the tumor as much as possible, If need be, there may be a need for a resection of the affected part of the bone. But usually radiotherapy and chemotherapy is effective at that, and surgery is reserved for non-responsive tumors, which tend to need limb-sparing treatment. Osteosarcoma, so this will be the first malignant tumor of the bone. It's the most common primary bone cancer, although some people do say that multiple myeloma is the most common, but it's widely renowned that an osteosarcoma is the most common primary bone tumor. And it's the malignant tumor of osteoblasts. As we've been mentioning all lecture long, not wrong, that an osteoblast is responsible for creating more bone. You can see in these X-rays here that there is definitely more bone here, especially on the outer rim, and the middle of the bone tends to be less dense, whereas the outer is very it's more dense on an X-ray. But in general life, the outer aspect of the bone in these patients is more stronger. Its epidemiology and the risk factors. It's more common in males. Once again, 10 to 25 years. That's the age bracket. As I mentioned before, Paget's disease, it can be a complication of Paget's disease. And for those with familial retinoblastoma or they've had previous exposure to radiation, they can also be predisposing factors to developing a osteosarcoma. Clinical presentation usually affects the metaphysis of the distal femur or the proximal tibia. It can cause pathological fractures because of this osteoblastic overexpression, and there will be some bone pain with some swelling. And as it's a sarcoma, it does metastasize to the lungs, unfortunately. Diagnosis, we can see, once again, the usual culprits here. We can see an X-ray, bone scan, CT, MRI, and the biopsy to confirm. On an X-ray, these images are not the greatest to see a Codman triangle, but the lesion, you can usually see a nice triangle in the bone, actually, and that's quite distinctive for an osteosarcoma. Treatment. Unfortunately, we can't use radiotherapy in osteosarcomas as it's not very effective. So usually in these cases, we use chemotherapy and then surgical resection, which would once again be limb saving and yeah, usually an amputation at that point. Next tumor is a giant cell tumor. So a giant cell tumor it's not a conventional tumor. It's a benign tumor of multinucleated giant cells and stromal cells. You can see here the soapy bubble appearance. It's more common in females between the ages of 20 and 40 years. And its clinical presentation usually affects epiphysis of long bones. So as we can see here, this is the epiphysis region of the radius, and it also can affect the distal femur of the proximal tibia. Typically, there will obviously be pain, and there can be some swelling, and it can be locally aggressive. And when I say locally aggressive, it can start to become a bit invasive, and it can invade soft tissue. So diagnosis: X-ray, bone scan, CT, MRI. This is a soapy bubble appearance, which is commonly seen in tumors such as this. It's not lytic; it's purely a soap bubble. Treatment would be bisphosphonates. Once again, radiotherapy in this case and surgery to remove this part of the bone which is affected. Ewing sarcoma. So this is once again a different cellular tumor, you could say, of the musculoskeletal system. But this is a malignant tumor of poorly differentiated cells, which are derived from the neuroectoderm. Genetically, it is linked with a translocation, and the translocation is from 11 to 22 chromosome. Most commonly, it is found in males in a young age category, so between 10 to 20 years. And it tends to affect the pelvic girdle and then the diaphysis and the metaphysis of bones, usually the proximal femur or the rib, but in this case, this is the radius. A very cachectic patient, I might add. Pathological fractures, not fevers. Sorry about this typo. And fevers and anemias because it's a malignant cancer, obviously. Diagnosis. I couldn't find a very nice image of an onion skin lesion, but usually on an X-ray you would find an onion skin type multi-layered lesion, which could be described as an exocytosis of the bone on both sides, and that is distinctive of Ewing sarcoma. Once again, bone scan for the densimetry, CT MRI, biopsy, and a or a multidisciplinary approach with chemo, radio, and then surgery once again. This is a chondroma. So this is a benign tumor of cartilage, and it has equal distribution between genders, more commonly in 20 to 50 years, or 20 to 50-year-old people. And it can be singular, or in this case here, it can be multiple. So there's one here, there's 2, 3, 4, 5, 6, 7. So there's 7 chondromas here in this patient. It tends to affect the medullary location in small bones of the hand and feet. Diagnosis, X-ray, biopsy to confirm. Treatment-wise, we tend to leave this alone. And really it's only surgery if it causes a fracture due to just a lytic lesion of the bone. So yeah, and there is also an argument to be made whether this is aesthetically pleasing, because it would be a very bulgy swelling in your bones, in your hands, which could maybe not appear the nicest of things to be showing around in public everywhere you go. So it could also be a reason for aesthetic surgery to take place. This is a chondrosarcoma. This is a malignant tumor of cartilage, most common in males between the ages of 30 to 60 years. Tends to affect the medulla, once again, of pelvic bones and the proximal femur, right here. And it can cause back pain and sciatica. This is more based on nerve impingement and affecting the nerve rather than the actual lesion here. It usually metastases to the lungs again. It's quite a common feature of all bone malignancies that they do metastasize to the lungs. Diagnose it by X-ray, CT MRI, biopsy. Treatment is mainly surgical. Amputation is not uncommon, as I mentioned here. Quite often there's very little we can do in patients with chondrosarcomas just because the lesions are so advanced and sometimes there's very little you can do, and in that case, an amputation is performed. There is a possibility for more proton therapy or proton radiation therapy to be used in the future. It's not a common mainstay just because of the expenses involved, but in the future it could be used, as there is an 80% effectiveness rate with proton therapy usage in chondrosarcomas, especially in the young. The prognosis is very good. It is resistant to chemotherapy and radiotherapy, however, and yeah, so that's why surgery is used. Right, now we're on to the kind of soft tissue tumors, adipose tissues. So this is a lipoma right here, and this is, you're looking at the dorsal aspect of the neck. So this is a lipoma here. This is a very large mass actually. Usually, most lipomas are less than 3 centimeters in their diameter, but this is a very large lesion, as you can see. But it's a benign lesion. And the epidemiology and the risk factors, most common in males between the ages of 40 and 60. There is a strong family history involved. So therefore, if your father or mother had a lipoma, the likelihood of you also having a lipoma is higher than it would be elsewhere. Obesity, purely because of more adipose tissue in your body, and lack of exercise, which is once again linked with obesity. Clinical presentation, here usually it's on the trunk or the neck or proximal activities. It's usually painless. It doesn't usually bother many people, and it's movable. So in the first slide, as I mentioned, an osteoma, it's a non-movable mass. This is movable. So this signal, when we say it's movable, we mean that it's very superficial, because if it was non-movable, then it would possibly have infiltrated muscle, therefore it would be less likely to move. Whereas if it's superficial, we can move it about. And aesthetically, it's obviously very irritating. And there's also many different types of lipoma. There can be adenolipomas, which are more common in sweat glands. There can be angiolipomas. There can also be angiolipoliomyomas, so even of soft tissues and soft muscle cells and blood vessels and connective tissue. Diagnosis, it's usually a physical exam and an X-ray as well, just to make sure it's not a bone mass. An ultrasound to see if it's not a cystic lesion and full of fluid, and an MRI just in case it's malignant. So this is a lipoma, so this is obviously a benign tumor, but in liposarcomas, they can obviously be very malignant, and they're usually found in the thigh and the retroperitoneum. So therefore, it's always useful sometimes to do an MRI just in case it is malignant, and you can catch the cancer before it's too malignant, you could say. Treatment, leave alone in most cases. Excision more for aesthetic purposes or convenience as well. Right, now we're coming to the last few tumors now, the last two. So this is a rhabdomyoma. This is a benign tumor of skeletal muscle. It's usually more commonly seen in the heart, and as a result, it's a heart tumor that is linked with tuberous sclerosis. So tuberous sclerosis is obviously a rare multi-system autosomal dominant genetic disease that can cause non-cancerous tumors in the brain, in the kidneys, liver, heart, lungs, etc. And so a cardiac tumor or a cardiac rhabdomyoma is linked with tuberous sclerosis complex. Can also affect the tongue and also the vagina, but more commonly it's usually the heart and then secondly the tongue. Treatment, surgical resection, because as you can imagine, this is the rhabdomyoma here. It could easily affect the volume in the compartment of the heart, and this could lead to reduced outflow, possibly depending on where the mass is. It could be, if it's in the right ventricle, for example, the right atrium, it could affect the pulmonary, the blood flow going to the lungs, and I suppose if it's on the left side, then it could potentially impact your arterial supply and the systemic circulation. As a result, treatment is always surgical. And then finally, rhabdomyosarcoma. So this is a malignant tumor of skeletal muscle. It's the most common sarcoma in kids. And genetics, this is a very, very complex topic with a rhabdomyosarcoma, and it's not completely well understood other than the fact that the genetic association is with the P53 oncogene, and it can use to control of the P53 tumor oncogene, along with the NRAS, the KRAS, and the NMYC oncogenes as well. There's different types, so they can be embryonal, can be alveolar, they can be pleomorphic, and then also spindle cell. Usually it tends to present in the head and neck, and it can also affect the genital system, so the penis and the vagina. It's more common in the vagina, and sometimes what we can see is a protruding grape-like mass from the vagina, which is very significant. Diagnosis is usually a biopsy. Treatment, so this is a multidisciplinary approach once again, so it's usually surgery, chemo, radiotherapy, and immunotherapy. This was tumors. Final thing that I will mention now is the neuromuscular junction pathology. So the first one is myasthenia gravis. So myasthenia gravis is when the body forms autoantibodies versus the acetylcholine receptor at the neuromuscular junction. This is usually in the postsynaptic membrane, as you can see here in this image. It's more common in females of any age, and it usually causes muscle weakness, which is proximal again, which worsens with use. And in the following slide, when I talk about Lambert-Eaton syndrome, we will notice that it's the reverse. Can also affect the eyes with ptosis and diplopia, so diplopia, double vision, ptosis, drooping of the eye. And it is often associated with a thymic mass or hyperplasia of the thymus. Its treatment is usually anti-acetylcholinesterase agents, and sometimes a thymectomy in the case of a thymic mass. Finally, Lambert-Eaton syndrome. This is when we have antibodies against the presynaptic calcium channels of the NMJ, and this results in impaired summation, which I haven't mentioned here, but it results in impaired conduction, actually, in summation of the calcium all the way to the postsynaptic receptors. And it's usually associated with paraneoplastic syndrome, very common in small cell lung cancers. It presents with proximal muscle weakness, which gets better with use. As I mentioned, it's the reverse of myasthenia gravis, and usually it doesn't involve the eyes. So we know that calcium will be released presynaptically, and that will cause the vesicles to approach the presynaptic membrane, and then they'll enter the cleft here for the acetylcholine to be released and for the transmission to carry on. And what happens is the antibodies are formed against this presynaptic calcium. Sorry about that. So this is Lambert-Eaton syndrome. And usually the treatment is resection of the cancer, of the lung cancer. So with this, this concludes my lecture today on pathology of the musculoskeletal system. I think it's an incredibly fun topic to learn, and my final thoughts on this would be to always structure your answers when you're approaching these pathologies. So always think of what the pathology is first, then if there's any genetic associations, the age demographic, for example, the epidemiology of the pathology, if there are any risk factors, and then we should talk about the clinical presentation. How do we find these cancers? Most of the time, it's usually a biopsy, not just cancers, but any pathology, and then also some scans, and sometimes we can also look at blood results as well. So these are my final take-home messages. I hope that today's lecture was useful, and if anyone would like to get in touch with me, my email is right here once again. If lastly, if I could just get everyone who watched this lecture, if they enjoyed it, if they could please fill out the feedback form, and yeah, I would really appreciate if you could fill out the feedback form. It's just a better way for us lecturers to kind of figure out what we did right, what we did wrong, and it's very useful for everyone involved. It's even great for CV purposes as well. So yeah, in terms of reflection, and I would greatly appreciate if you could fill out the feedback form. I think with that, I would like to conclude today's pathology talk. Once again, thank you for joining me. I hope this was useful, and I hope to see you again at some other of our pathology lectures, and also our rapid review physiology lectures, and all of the other fantastic events that our team is constantly organizing. So thank you very much for joining, and I wish you a pleasant day, and thank you very much.